Hi guys, my name is Dr. Michelle Zatuni, and today we're going to talk a little bit about sleepiness and the effect, particularly for healthcare workers. But you'll see there's some information here about driving and drivers statistics, and just general for the general public. First, what is sleepiness? Sleepiness is a complex reversible state. It's characterized by behavioral quiescence. So people are generally going to be more still. They're going to be in a recumbent or lateral type of position. And if they are not in those positions, gravity will try and take them to that position. But it also requires a diminished response to the external environment. So noises, smells, light, people are not going to be as responsive to. There's no unified theory as to why people sleep, but what we know mostly about sleep happens to be because of sleep deprivation. And since we have kind of discovered that people that are sleep deprived do not function very well and it can be dangerous, these studies are not really going to be happening over again. And where we know a lot about dysfunctional personality issues, things happen during the day, and people that are not functioning well, we'll be able to study those, but not like we would maybe in a controlled lab setting. There's a definite structure that happens with most adults and children in terms of what normal sleep is, and we can see abnormalities when we study it in a lab in people with functional abnormalities. And this is a really important point, is because a lot of people are going to notice that they have sleep disturbance based on other parameters. So, for example, trouble maintaining concentration during the day, during their work or during school, and people maintaining alertness during driving or during highly skilled type of activities. So think about a surgeon. And also there's a element of not feeling good during the day. So depressed mood, decreased enjoyment levels, other medical issues that can pop up, particularly those of the sympathetic hyperarousal disorders in children, and other ones in terms of just kind of some delayed and slowed down effects in terms of adults. But behavioral issues, people become more aggressive, just different personality traits. Memory problems are huge. So a lot of neurologists will see disorders with sleep because of poor memory. So when someone gets initially sleep deprived, like anybody that I'm talking to in this audience, you've had days where you've been on call, or you haven't had as good sleep, maybe before an exam, or because you've had to wake up much earlier than expected. And during that next day, you function pretty okay. Well, if this happens for a few weeks or months, and then think about somebody who it's happening for quite a few years, there is going to be that element, particularly at about the few weeks part, where there's an increased level of sleepiness, delayed amount of vigilance, maybe even a component of apathy that develops. But they've studied it, and there's also a decreased pain tolerance, a decreased seizure threshold, hormone dysregulation, and even your immune function is going to be decreased. And they studied this in particular with persons that got influenza vaccines and their degree of antibodies that developed, and also people after getting hepatitis A vaccines. You just don't function as optimally as an organism when there's an element of sleep deprivation. There's a few things to kind of go back on when you talk about sleep deprivation. Is it a selective sleep deprivation, which is the type of experiment we'd be able to do now, or a total sleep deprivation, such as they've done in military camps that we generally cannot reproduce here in the human population? I put here on the last part of this slide about even a decreased febrile response to endotoxin. So when your body gets exposed to a bacteria that produces endotoxin, think about like strep pneumonia, there's a decreased ability for you to mount that normal response to have a fever that would be helpful for you to fight off that infection. So This is a slide from National Sleep Foundation and the National Highway Transportation Association talking about driving statistics. And I've updated it. They update it every 10 years. So the most recent is from 2020, and we know 2020 data are pushed out, but obviously things that are going to be pushed out in 2030 will be vastly different in terms of what our numbers look like, because for the last 4 or 5 years, we've been working in a somewhat hybrid virtual environment. So there's a lot less people on the roads, but there are quite a few people that cannot be off the roads just because of what they do. So commercial drivers, and even professional people that actually have to commute for work. But drowsy sleeping causes 250,000 car crashes a year. And many of these are going to be more dangerous car crashes involving more fatalities than those of just the hitting the bumper. So in the data from 2010, about 6% of fatal crashes, which has gone up from previous years when it was around the 1 or 2%, and now we're looking at closer to 12 to 15% in 2020. 71,000 injuries, $12.5 billion of monetary loss. And it's very similar, especially when we're doing simulated driving, not actual driving, to that of driving above the legal limit of alcohol. 25% of professional drivers have fallen asleep at work, and these are reported by their supervisors. If we self-report, it's much less, and that would make sense because their livelihood does depend on their ability to function well at work. But when we're asking the supervisors, they've either observed or heard it from other coworkers that are concerned. It's much higher. 1 in 10% of employees has been late due to a sleep factor, and sleep disturbances in general and trouble sleeping at night, which will contribute to delayed ability to function during high performance periods such as driving or being able to show up to work at the right time. This will affect 1 in 3. So drowsiness is defined as the desire to sleep. And it's important for you to recognize that your body does give you these clues. They make different measures happen depending on the degree of sleepiness, but it's the equivalent of what your body tells you when you are thirsty and that you need water, you need food. All sleep is important and required for people, but you have to kind of understand over the years, employers and agencies have created, different perversions of what sleep look like. So very popular is this two distinct sleep periods of time, an early evening or late afternoon, and then being up and then being asked to re-perform and go back to work in the middle of the night. And some people take this to be, this is like really efficient and that this would be a great thing to do. But ultimately what this does is it breaks up your one nice nocturnal sleep period into 2 periods. And how sleep works is you have to actually maintain sleep and sleepiness for a longer duration to be able to get into your REM cycles. So it's important to recognize that just because it might sound good or it can be done, such as what you might experience in a hospital setting or being on call, is not necessarily the healthiest thing for the human body. So the factors that influence sleepiness are multiple, but we're typically run on 2 different boats, okay? So the one is the circadian rhythm, which is in humans the ability to get sleepy and sleep at night, just depending on the light-dark cycle. So we have hormones and behavioral systems that are set in so that we get sleepier at night. And that can vary depending on the person, but as the sun goes down, usually it's about 2 hours or so later. So this time of year, it's going to run somewhere between 9 and 11 p.m. And as daylight savings time versus going to more standard time, that's going to change. So we can't really control our circadian pattern, which is why we probably should not change time change and cause this, half a year to be dysregulated and to be an hour off of our natural circadian rhythm. The homeostatic drive is run by how active and how much you have earned your sleepiness. So this is an effect of how active an individual is. And so for somebody who's like you that is generally more sleep deprived on a regular basis due to work demands and home demands versus someone who's retired, who may not be exercising and having a full active day, they may not earn as much sleepiness during the day and not be as driven to sleep at night versus just that whole night dark cycle. So think of in the emergency room setting where an emergency room physician is now sleeping off of their circadian pathway. They might be working at night and being asked to sleep during the day because they have been active and they've been awake, alert, and functioning for their 12 or 15 hours in the middle of the night. They're actually more able to go to sleep the next day versus, you maybe if you're on call and by effect, you're going to be working that night. So you might take, shorter nap periods during the day, maybe get a better night's sleep for 2 or 3 days prior to doing that night shift call. You may not earn that amount of sleep that ER doctor is working, whether or not they're working 5 days a week on the same schedule or whether or not they're just shifting from a day shift to a night shift. So those are the two factors. The circadian factor is light dark dependent and homeostatic is the individual drive. And here we're going to talk a little bit about that more and why that happens. But the circadian rhythm is built based on the part of your brain that responds to the light dark nucleus or the light dark cycle. It's the suprachiasmatic nucleus. It sits right behind your brain. It will trigger the pineal gland to release more melatonin. Pineal gland is the only organ in our bodies that releases this hormone, but many foods contain the precursors to our melatonin and can actually be converted actively to melatonin from other substances. So think about turkey, but also tuna, bananas, almonds can also have this. Here's the homeostatic drive, and I kind of like this one sentence. I think it explains it really well. The longer your body has been awake, there will be an increased drive for it to sleep. And this varies, but in most adults, it's going to be somewhere between 7 or 8 hours. If your body gets not enough sleep on one night, it will build up this sleep debt. And a lot of people, think about teenagers or just people sitting here in this room. If you build up enough sleep debt, you'll have a much easier time going to sleep. It doesn't mean that it repays all of the debt from the couple nights that you did not get good sleep. So drowsy people don't even recognize how sleepy that they are, and they are creating a hazardous condition in medicine, both for their patients and for themselves. And as I mentioned before, it is the equivalent of using another substance like alcohol. Just a few hours lost each night can be the equivalent of being under the influence. The sleep surveys show that more than 2/3 of surveyed adults don't get enough sleep, and they actually don't feel well during the day. And that's a lot of people. So when you thought that number of people that have insomnia or experience insomnia is 1 in 3, we've now doubled that in the number of people who feel sleepy or feel that they're not getting as much rest. A lot of, I would call them gadgets or gimmicks have been developed to try and help people try and stay awake. So in driving, it's, rolling down the window, turning on the air conditioning, biting your hand or kind of contributing to a little bit of pain. Some people will eat or drink liquids. Some people smoke. Some people chew gum. And a lot of people will negotiate like, oh, I'm just going to wait 5 more minutes and then I'm going to pull over. Oh, I'm just going to wait until like the next town over because there is a strong urgency to drive. In the studying world, if you don't finish studying, you have negative implications of not doing well on the test. If you have charts to do, again, there's the negative implication of not being as prepared the next day. But the important thing to recognize is that not getting enough hours of sleep will impair you, and you actually may do worse as a result of not getting sleep, not just finishing things at the end of the day. And in medicine, that's really important. In the surgical literature, the surgeons who got less than 6 hours of sleep had an 83% increased risk of severe complications. And you can see these massive hemorrhage, organ wound failure, and these really translate quite well to actionable, um, problems that take place during the day. So much so that just like commercial pilots, surgeons are not allowed to be on call multiple nights in a row like they have been in the past. And surgeons that have completed a case aren't going to be scheduled for more surgery, so they are required to have that rest period. Many hospitals have gone to actually having those like sleep rooms or the little rest area rooms to be able to allow those surgeons to take that time. Whether or not they will depends on a culture. So that's really one of the things that I think is pretty fantastic about the hospital system that you work in, is they really have taken a lot of ownership to saying, hey, we want to decrease medical errors, we want to make sure people are educated, and we don't want to punish people that recognize that they're having a problem with sleepiness or that they didn't get enough sleep. And so they allow you to, go to your preceptors, go to your supervisor and say, listen, I'm going to need to take a break because I don't have enough sleep and I'm feeling sleepy. So it's really important to recognize that to be able to move on. Okay, so recognition of insufficient sleep is the first step. And so I want to talk a little bit about what might be little red flags. So getting less than 8 hours of sleep is a red flag. Now, for some people, they do very well on 6 to 8 hours of sleep. But what about those people getting less than 6 hours of sleep? There's very good data that even people who feel that they function well on less than 6 hours of sleep will miss more things. They will have more problems. There's a very, very small set of people out there that actually do the best on around 4 hours of sleep. There's a genetic component to it, and it's by far the minority. If you're waking up the night multiple times, so whether it's phone calls waking up, or personal issues waking up, maybe medical issues or a child or a pet. If you have trouble falling asleep at night and not feeling refreshed the next day, when you wake up after however many hours of sleep that you've slept, and then you still feel tired within a few hours, that's very unusual versus that mid-afternoon circadian lull that I didn't quite get to on my slide with the circadian rhythm. But when people are on a entrained regular light dark cycle, there's that period somewhere between 12 and 4, but definitely 1 to 3 in the afternoon. Well, they'll feel tired despite getting a good amount of sleep, but be pretty unusual if it was between 9 to 11 in the morning in that person. So if you've ever fallen asleep driving or been near falling asleep driving, if people snore, and also it's really important to ask about waking up sweaty. So it's not just menopausal women that will wake up sweaty, but there's a very specific and distinct sweatiness that can develop, particularly if it's in the upper part of your body or just behind your head and your neck. That may be more of a sign of a sympathetic overdrive, and we see it a lot in patients with sleep apnea. So this is the National Sleep Foundation poll, where 2/3 of the responders noted getting less than 6 hours of sleep. And you can see they broke it down in males and females, and also the graph of the less than the 7 hours. This is by state, okay? And so you can see Vermont has the highest amount of sleep, and Hawaii getting the least amount of sleep. So this is an age-adjusted prevalence of the number of people that are getting insufficient sleep. So not surprising that someplace maybe like Nevada that has 3 different shifts, but many of the other places, I would suspect that you're not surprised of these orange areas. They're high in manufacturing, they're high in in persons that might have longer commutes. And also, there's a predominance for the light dark cycles. So the days are quite a bit longer in the upper parts of the United States than in the lower parts of the United States. But the factors that influence sleep may include personal factors internal, personal factors external, okay, like environmental noises, light and temperature, and then these other issues. So maybe external factors if you're a care provider for someone else, or if you cannot control, I don't know, like the phone calls that you're getting from the floor. Medical problems, again, just a partial list. You can see that everything from lung disease, heart disease, hormone problems, um, the getting up frequently at night to pee, prostate issues, all of these things. And then you also have the medicines that treat some of these, contributing to some of the sleep disturbances. So you can see that every person who gets hospitalized is basically a potential sleep patient. And you, by being there at night to take care of these patients, you are also creating a sleep issue. So, because not a lot of you understand what specific conditions that sleep medicine treats, I put the specific sleep problems in there. So, not just the medical issues that contribute to sleep, but primary sleep disorders that disrupt sleep. So, by far, what people recognize as pulmonary and sleep specialists taking care of are the sleep-related breathing disorders that vary everything from snoring to some complex sleep disorders, and just not ventilating well at night, as we see in our chronic lung patients. But there's also restless leg syndromes, these periodic limb movements, which is not restless leg. Periodic limb movements is a diagnostic from a sleep test where there's a repetitive movement of the legs. It will co-occur in people with restless leg, but people aren't aware of it. They will present predominantly with just tired during the day, no matter how many hours of sleep that they get, and then will be found on a sleep test to be twitching all night. Narcolepsy, which is pretty rare, but it is a problem with the sleep-wake cycle. So they have disturbed nighttime sleep, and then they're sleepy during the day. There's 4 other constellation of symptoms that occur with narcolepsy. So they're important just question from a diagnosis perspective and getting a history of maybe very vivid dreams, audiovisual hallucinations, sleep paralysis, which is where you are asleep, but as you're waking up, your brain is waking up before your body wakes up. And that can be very frightening for people. So it's interesting when you actually ask if they've had sleep paralysis and then describe it, and they didn't really have an answer for it, but it was a fear they had. Parasomnias are disorders that occur during sleep. More of them occur in non-REM sleep than in REM sleep, but where something happens during sleep that typically would happen during wake period. So walking, talking, eating, cooking, sex, like there's a lot of these parasomnias. We used to include teeth grinding in this parasomnia, but teeth grinding is actually felt to be more of a falling asleep type of disorder, and it's a transitional behavior. So it's grouped a little bit separate than general parasomnias, but still happens and still can disrupt sleep. The circadian rhythm disorders, this involves the shift workers, but also the people who get sleepy much earlier and are waking up much earlier, or vice versa. And insomnia. So the 2 most common primary sleep disorders being sleep disordered breathing that I treat, and also the primary insomnias. Insomnia can be trouble falling asleep, or trouble staying asleep, or waking up much earlier than your anticipated or desired wake up time. But it must be accompanied by some dysfunction during the day. So you can't just say, hey, I just go to bed late and I'm tired in the day because I have to show up at work at a certain time. This actually has to cause some sort of dysfunction for that person in the day. There's a statistic that 80% of people that were ever diagnosed with insomnia or with anxiety or depression will have episodes of insomnia in some time in their life. And these insomnia periods are not just episodic. They may last 3 months or longer. So there's something that's an overlap of insomnia and sleep disordered breathing, and about a third of people will have this. And the word is called COMISA, COMISA, COMISA. And a third of patients with sleep disordered breathing may have this, and a third of patients with insomnia may have sleep disordered breathing. So in my clinical practice, it's really important if someone's coming in with just trouble falling asleep or staying asleep, I'm still going to ask them about breathing difficulties at night or waking up sweating, because it's a really common overlap. And compared with people that just have sleep apnea, the people that have sleep apnea and insomnia together, they will have harder to treat insomnia, and they will have more problems with their dysfunction during the day. And they will be really a lot harder to treat, particularly if they believe that their insomnia is the primary problem. They will oftentimes fight some of the treatment for apnea. Now, if you can get both addressed simultaneously, that can be very helpful, but many times they're coming to see someone not a sleep specialist first, who will address one thing after another, and the patients actually feel in the back end that they're just going to be sleepy and they're just going to sleep badly, or that whatever the doctor that prescribed for them just isn't working. So remember, most sedative hypnotic type of agents that are used for sleep are actually going to worsen breathing disturbances. But there's a high number of all-cause hospital patients that are going to have this overlap. It's just important to recognize. So sleep disordered breathing is kind of the term, if you haven't had a formal sleep test and you don't know that you have sleep apnea, it is the overlap where there's a problem with the upper airway contributing to ventilation. And so that's the big part. The obstructive sleep apnea syndrome is a cyclical period of where you stop breathing. So someone who stops breathing more than 5 times per hour and has some daytime symptoms is going to have clinical apnea that we can treat. Someone who has less than 5 times per hour, that they have 10 seconds or longer apnea, is going to fall into that sleep-related breathing category, which, and if they have symptoms, we still would end up treating, but their insurance may not allow us to pursue all the treatment options for them. So it's an important thing to catch in between. You stop breathing between 5 and 15 times per hour and have symptoms, you have mild sleep apnea. If you stop breathing between 15 and 30 times per hour, that's moderate sleep apnea, and that's whether or not you have symptoms or not. And over 30 times per hour is obstructive sleep apnea syndrome that is severe. So we don't just call it severe and then more severe if it's over 100 times per hour. But those patients oftentimes are going to have more of the sequela from the cardiovascular neurologic system than someone that has more mild sleep apnea or body position dependent. In obstructive sleep apnea syndrome, you can also have some extra types of apnea where it's not an obstructive picture, but it's more of a central picture. And in that group of patients, we have to look for other underlying medical issues like neurologic or respiratory issues that might contribute to a periodic breathing, like Cheyne-Stokes respiratory pattern or primary central sleep apnea. Central sleep apnea is part of sleep disordered breathing and is part of an airway issue, but it's secondary to the primary issue of being neurologic. Think about the case of somebody on narcotics. So symptoms of sleep apnea can be the snoring, the gasping, watching somebody not breathing, choking, but daytime sleepiness, headaches, fatigue, bad concentration, and also mood disturbances. So you can see that other than the respiratory complaints, a lot of them may overlap with just our primary insomnia people. All right. How to make the best of the sleep, okay? So when you can possibly do it, you really want to dedicate an 8 hours of opportunity to sleep. Doesn't mean you get into bed if you're wide awake. What it does mean is that you give yourself enough opportunity to allow for 8 hours of sleep. So that can't always happen, particularly in a hospital, rotation, or it can't always happen with traveling or studying for exams. But really try to give yourself that opportunity. And when you cannot and you're getting less opportunity, let's say 6 or 7 hours, then what you want to make sure that you do is you have these good habits during the time that you are trying to fall asleep, and that's called sleep hygiene, or sometimes it's called stimulus control strategies, like avoiding having the television on in the room, making sure that it's cool and it's a quiet place for you to sleep. But in the morning, making sure that you have as bright lights as you can tolerate, hydrating, not dehydrating yourself with a bunch of caffeine. And then during the day, making sure that you're staying nourished and staying as active as possible. So I put an asterisk by the napping, because napping, if you're getting over 8 hours of opportunity to sleep and about 8 hours of sleep, would not be ideal. But getting 6 hours of sleep, or even less than 6 hours of sleep at night, would like to try to optimize napping. So there are 3 different types of naps that are kind of defined, but planned napping is also called preparatory napping, and this involves you taking a nap when you get sleepy. So in the case of the person who wakes up much earlier than ideal and it goes to bed later than they may like, they would anticipate taking a nap in the afternoon. And this could be late afternoon, early afternoon, but when they're sleepy. So it's important that you plan the nap during periods of time when you're sleepy. And this is something that I used to do a fair amount when I would know that I was going to be on call, or when I would have meetings that were really late at night, after midnight, in the intensive care unit. Sometimes we had these types of meetings. But a planned nap is a set nap opportunity where you set a timer, you set a place, and you know that you're going to get sleepy. When you get sleepy, then you take this nap. So it implies that you are not already doing something in the middle of it by the time that you have to get sleepy. That's when emergency napping happens. So emergency napping is where you start getting sleepy, whatever you're doing, and you catch yourself while you're getting sleepy. You remove yourself from the situation where you're getting sleepy and it's not appropriate, and you take yourself to a place that is safe to sleep, and you set a set amount of time for that. So classic example in maybe a medical student might be noon lecture. And during this noon lecture, if you are catching your head kind of falling, is not just keeping your head down at the noon lecture, but maybe getting yourself to either the call room or like a classroom where you can put your head down and finish maybe taking that 10 or 15 minute nap so that you can go on with your afternoon. What happens though is if you're fighting that nap during the whether it's a lecture or during a procedure, what happens is you're actually not giving your body sleep, and the rest of that day you're going to still have that impairment that you had at that lecture, particularly if it's during your circadian drop. Okay, so planned napping is something that I would say would be a very helpful thing. Not so disruptive because you're putting that into your schedule. Emergency napping is disruptive. You've now missed out on a portion of a lecture. You've now, if you haven't done that, you've put yourself and others at risk for falling asleep doing something that might be important. In commercial drivers, when they do emergency napping, we tell them to pull off immediately wherever that they are, remove themselves from the driver's seat. The driver's seat is somewhere where they are on. Okay, that would be like this falling asleep in lecture, and taking themselves into a place that would be an appropriate place to nap, either in their bed cab area, or on a bench where they would normally be able to take a nap in a safe spot. Habitual napping is practiced at the same time every day, and it is something that we see in younger people, like under 5 years old, and older people over 65 years old, where habitual napping is a normal part of getting yourself enough hours of sleep. So young children, under 4 or 5 years old, need 11 to 13 hours of sleep. Sometimes under a year old, they're going to need 15 to 18 hours of sleep. And so there's not a nighttime period that's going to provide enough of that time. So it's supplemented with a habitual nap. at a predetermined time. In very young children, it's mid-morning. In a little bit older children, it might be early afternoon. And in older persons, we try and kind of combine it with that circadian lull, because it's more likely that they'll be able to have a solid nap opportunity and not interfere with their nighttime sleep. Napping too late, closer to your bedtime, is going to interfere with your sleep. Napping too early, where you're not sleepy, you just won't be able to maintain that sleep period. So it will almost cause you to feel like you didn't sleep. And many people will say, "Hey, I just try to go to sleep and I can't." So napping tips is keep it shorter. The shorter the nap, the more likely that you're not going to wake up from one of the deeper stages of sleep where you'll feel more tired. You want to make sure that your surroundings are appropriate for napping. So again, quiet, cool, comfortable, where there's less interruptions, and your body's supported so that you're not constantly using your muscle tension to kind of refresh you or revive you from sleep. And then not taking the nap too late. So if you're sleepy and you're driving, you want to pull over immediately and never nap in the driver's seat. You want to make sure that you're not using cruise control. You want to make sure that you are active and engaged. And then you want to keep your mind active. And this doesn't mean you're supposed to, play Sudoku while you're driving. But what it does mean is you might be looking for specific cars or looking for license plates, which can be very helpful. Keeping the nap short, not necessarily using the music to keep you awake, but try not to use music that's actually promoting more sleepiness. You don't want to do the breathing type of exercises that help your parasympathetic drive up. You'd probably try and like something that's more sympathetic driven. If you start needing external factors like more devices or food or something that you've purchased to see if your head starts dropping, like in the commercial driver world, probably means you should take a break and stop. So why I like to talk about screening for sleep issues is because we're not immune to sleep issues. And I would say the vast majority of us sitting in the room may not get enough hours of sleep at night. And you can screen for how sleepy are you. The Epworth Sleepiness Scale is from the mid-'80s, and it's been validated for decades now. It's not a great test, again, for the commercial drivers who want to report themselves as having 0 on everything, because they know that if they are reported as sleepy, they will either not be able to maintain their livelihood, or they'll have to go through some remediation efforts. But you can see is the chances of dozing being like never at all or all the time, doing certain activities. So there's 8 questions. You can get score up to 24, so 8 times 3, 24, or down to 0. Normal for this test is less than 8. 8 to 12 is kind of a marginal or borderline sleepiness. Over 12, definite sleepiness. Over 15, pathologic sleepiness. So in someone with narcolepsy or someone who routinely is getting less than 4 hours of sleep, you're going to see pathologic sleepiness. For the vast majority of people in this room, I would expect that it would be less than 15, but you'd be surprised. And these questions vary as, sitting in active public place where nothing else is going on, lying down in the afternoon. We already said that is an opportunity for some people to sleep. But talking to someone and falling asleep in traffic, those are obviously some pretty serious sleepy effects. The Berlin questionnaire I put in here because it's handed out at a fair amount of health screening. It's specific and sensitive for testing for obstructive sleep apnea. The first box you can see has to do with snoring. Second box has to do with the sleepiness. And then the third box is a sum of the other risk factors that are associated, like your body mass index or your blood pressure. And then we categorize it based on that. So there's category 1, category 2, category 3. Okay, and if these things add up to more than 2, your chances of having apnea are high in any of the boxes. Okay, so positive, positive, positive. You get more than 2 positives. We kind of say that you're screening positive. And then stop bang is the newest to be added. This was added probably, I'm going to say they did the trials in 2015 to 2020. Was in the surgical literature. So this was a anesthesia question. It's by Dr. Chung. She published it in 2008, and then they were using it in many hospitals here since then, and it's been published multiple times. But it's a questionnaire that's based on the acronym of stop bang. So S is for snoring, T is for feeling tired, O is actually someone observed you stop breathing before, P is for blood pressure, and then the bang is the BMI of over 35, age of over 50, neck is greater than 16 inches, and G is for gender that's male. Now, this is taking account every stereotype of a sleep apnea patient ever, and you are going to pick up a lot of them. But think about women, think about the non-obese people. Age and menopausal status are somewhat synonymous, but I will tell you that that is one of the biggest risk factors in women, so you have to figure this out. And tired and sleepy are not the same thing, so the fact that those are kind of in the same question is there. But if you have a number of over 5, you are strongly going to be positive for sleep apnea. And I really find that if you are doing stop bang in the pre-op for a surgery that's already scheduled with a surgeon that's already there, this is a little bit late. But if you have heads up, a week or two prior to the surgery, you can appropriately identify patients and maybe have a chance to either get them treated prior, or at least advise them if they, oh yeah, I have sleep apnea, I was told to do this, but maybe advise the surgeon how you would like to proceed with the anesthesia, or prepare for them some bed after they have their elective surgery. All right, so we're going to talk a little bit about sleep hygiene, and then we'll end for this lecture. But sleep hygiene is that overlap between things that you can do appropriately to get ready for appropriate sleep time. And one of the biggest things that I tend to focus on is having a regular schedule, and of like between nighttime and daytime, it's much more important for you to have a regular wake up time, even as difficult as that is sometimes. And the second one is to stop watching the clock. So when you aren't sleeping well, or you have a deadline to be able to get to sleep or to finish your studying, is make sure that when you start feeling sleepy, that becomes your deadline as opposed to the clock. You want to make sure your environment is cool, dark, quiet. If you want to have, kind of a sound machine or some buffer to the sound. So if you're sleeping in the hospital in particular, and, all of the noises from the intensive care unit or the paging overhead, having some sort of white noise that can mask some of those disruptions that happen that are out of your control could be helpful. You want to try and practice a relaxing routine, reduce your time in bed, and really make sure that you're not medicating yourself on a regular basis for sleep. There's certain times that becomes kind of an appropriate, anticipated thing to do, but you shouldn't just routinely try to say you have to medicate yourself for sleep. Okay. So stimulus control is your bedroom is equal to sleep, and so that you want to make sure that you don't train your body to be in your bed or your bedroom awake. And this is one of the things that really popped up after COVID, is where people were eating, sleeping, working, studying, talking on the phone. They were doing everything in their bed and their bedroom, and we need to really work on getting away from this, because it creates a difficulty, especially when you are, having work meetings or stressful situations, and you're taking it technically into your bed. So that's what stimulus control is. Also, anything that doesn't belong in the bedroom that will help with sleep, like television or your iPad, things like that, just try and remove them from the bedroom. One of the medicines that we do a lot is wake promoting agents for shift workers, and armodafinil, which is Nuvigil. This was a really popular medicine for a long time. We actually have some different things now. But the whole idea was, well, we can't give these types of medicines to people that have either high blood pressure or at risk for high blood pressure. And when you look at the actual data, just notice that this works on dopamine in the brain and it doesn't work on the norepinephrine type of receptors. So it is not a traditional stimulant, it's a wake promoting agent. And I put that out there because a lot of people will say, well, I either have high blood pressure, anxiety, and I cannot take medicines to help keep me awake even if I'm sleepy. So just you can look at the actual heart rates, diastolic and systolic blood pressure. They were pretty similar between placebo and armodafinil. It should be noted, though, they studied the 150 dose of armodafinil, which is the lower dose. So just look at that. So seeking the help of a professional when you do think that you have a sleep disorder or you recognize that your sleep is not optimized and you may be impaired, while you're at work. I always tell people, sleep specialists, there's not that many of us, but almost everybody can become their at least initial sleep specialist, looking for cognitive behavioral therapy, working on your breathing and just working on nasal breathing, doing some biofeedback and relaxation therapy, and then getting back to what you said, is make sure your bedroom is conducive to sleeping appropriately. Okay. When the chances of falling asleep are high, it may be best to stop driving. And I always tell people about this because I had a good friend in medical school. His name was Barang, and he and his friend, who was another classmate of mine named Ben, they were driving home from a YouTube concert, and this was after a rotation. I was on that rotation with them, and I had left much earlier in the day. They were going to a YouTube concert in King of Prussia, which is right outside of Philadelphia, and they fell asleep driving. He was driving and he didn't have a chance. He was went right into oncoming traffic and then turned off onto a road. And so I always think about it. It's not something that could have happened any other time, but we all think that it won't happen to us, and it could have been really solved with doing a little bit of, I don't know, homework, splitting something, even just going to a rest area could have been something that was helpful to save their lives. Prescription and over-the-counter medicines list drowsiness as a common side effect, and then the inverse is true too, is a lot of things that you take may actually keep you awake. So sometimes your sleep deprivation is kind of self-imposed because you may be taking something that might be there to help you, but on one side it's affecting you in a different way. Driving drowsy is more dangerous than driving intoxicated. There's a lot of work with driving while texting. Again, these are distracted periods, and in stage 1 sleep, you really don't even know that you're sleepy until you've fallen asleep. It impairs your senses. You can be arrested for driving under the influence, and sleep deprivation sometimes counts. It's a little harder to prove, but really beware of these little micro sleeps that can land you a football field length away in a second. Now, never take a nap in the driver's seat. It's just really that easy to start programming yourself to not be sleeping where you're supposed to be awake and be awake where you're supposed to be sleeping. So that's part of that stimulus control. And I will take any questions if it's helpful. Sleep is a great field to go into. I wanted to maybe start out by telling you that not most people, start out and say, hey, I really want to be a sleep specialist. But if you go into medicine and you say, I really want to make a difference and I want to work on something that's really preventative, then look into the field of sleep from internal medicine, family practice, neurology, psychiatry. It's a 1-year fellowship. It's getting harder and harder to find some of these fellowships because many of them are being sucked into kind of a combined sort of field or getting into a clinical pathway. But feel free to reach out to me. I put my email on here, or you can call my office. I really encourage the field. I think it's a great field, and it's a really very proactive and preventative field to go into, even though we are also taking care of a lot of these sleep disorders. And with that, I will end. Thank you for your time.